the status epilepticus in the coming 25 minutes. This is my disclosure. I'll go over the topic, talking about the background and some definitions and classification of status epilepticus and refractory and super-refractory status epilepticus. Then I'll go over the clinical approach for management of patients who presented with refractory and super-refractory status epilepticus. Then I'll go over treatment overview. So as we know, status epilepticus is common in both children and adult age group. It's more common in children, particularly in age less than 2 years. And it is more common with patients who has epilepsy. Around 1/3 of cases with epilepsy, they can present for the first time with status epilepticus. The incidence range from 15 to 20 cases per 100,000 people. And it occurs more than around 30,000 children annually. They can present with status epilepticus. It can be as a first seizure of subsequent epilepsy in approximately 1/3 of cases. In another third, as I mentioned, it can present in a well-known patient who has epilepsy. What about refractory and super-refractory status epilepticus? Refractory status epilepticus occur around 9 to 43% of all cases of status epilepticus. You can notice that there is a variation in the percentage, and that is depend on multiple factors, including the criteria and the study design. The super-refractory status epilepticus occur in around 10 to 15% of cases with status epilepticus. It is a potentially life-threatening condition, and if we are not interfering early, it will lead to subsequent neurological deficit. Mortality rate around 22% in children, and in adults around 57%. However, if I mentioned, if you interfere early and start early treatment, the mortality rate will be reducing to 1 to 5%. Status epilepticus in general is defined as a persistent or recurrent seizure due to failure of seizure termination mechanism. And International League Against Epilepsy, in their task force for classification on status epilepticus, they divide the status epilepticus to 2 stages, after time point T1 and after time point to T2. And what do you mean by after time point T1? Is a condition resulting either from the failure of mechanism responsible for seizure termination or from initiation of mechanism which lead to abnormally prolonged seizure. In the after time point T2 is defined as a condition who have long-term sequences, including neuronal death and neuronal injury. And this is in summary for the first time point T1. Marks as a continuous seizure activity and identified the time when treatment should be started. And the second time point T2 is the time of ongoing seizure activity beyond which there is a risk of long-term sequences and sequelae. And the operational definition defined the T1 in cases with tonic-clonic status epilepticus to be 5 minutes, and in focal status with impaired consciousness defined as 10 minutes. However, in T2 is defined at 30 minutes in generalized tonic-clonic status epilepticus, and in focal more than 60 minutes. In the absence, the T1 is defined as 10 to 15 minutes. However, the T2 is unknown because we don't know after how long the sequelae and neurological damage will happen with prolonged status epilepticus, in absence status epilepticus. The refractory status epilepticus is a continuous seizure activity not controlled by first line and second line anti-seizure medication. Super-refractory is defined as if the status is not controlled by third line agent or if status continued for 24 hours or longer after anesthetic agent administered. New onset refractory status epilepticus is defined if you have a patient who presented, a healthy individual who presented for the first time with a new onset refractory status epilepticus without identifiable etiology. Another condition is fire, which will be also febrile seizure related refractory status epilepticus, which will be discussed, I think, in the coming day. It present in several forms, either to be convulsive status epilepticus, consisting of repeated generalized tonic-clonic convulsion, or non-convulsive status epilepticus, or to be repeated partial seizure or focal seizure manifested as a focal motor or focal sensory or focal impairment of function, like aphasia, which is not associated with altered awareness, which is, we mean with this epilepsia partialis continuum. The classification of status epilepticus divided up to 4 axes. The first axis related to semiology, the second axis to etiology, EEG correlate, and age also. So for the semiology, either to have a status with motor component or without motor component, and the etiology, it depends if it is symptomatic etiology or unknown. However, classification based on seizure type, we have focal, generalized, or undetermined, and pseudo seizure or pseudo status. And this is very important to consider because you have to identify initially if the patient is having really a seizure, a real seizure, or a pseudo seizure. For the etiology, it's divided to either to be acute or remote or progressive, or if there is a defined electroclinical syndrome. A common etiology for status epilepticus can be secondary to cerebrovascular accident, or CNS infection, neurodegenerative disease, intracranial tumor, cortical dysplasia, head trauma, alcohol-related intoxication, withdrawal or low level of anti-seizure medication, cerebral hypoxia or anoxia, metabolic disturbance, autoimmune disorder, as well as mitochondrial diseases. So all these etiologies you have to consider in any patient who presented with the status epilepticus. The aim for the treatment and management of status epilepticus and refractory status epilepticus to achieve seizure control, to treat underlying etiology, and to manage and prevent complication from the status. In general, we have to consider continuous anesthetic agent in any patient with refractory status epilepticus. Continuous infusion usually maintained for like 24 to 48 hours before it's weaned. And of course, continuous EEG monitoring is recommended in cases of refractory and super refractory status epilepticus. This is the diagram of our guidelines for status epilepticus. And you can see here we are talking about this part of the clinical practice guidelines, and you can see clearly that there is no clear reference of medication over another medication. You can see here we wrote midazolam or thiopental or pentobarbital. So the evidence for the guidelines for treatment of refractory and super refractory status epilepticus is not well established. And this is diagram showing how to approach a patient who presented with refractory status epilepticus. So we have to start with medical management with using benzodiazepine, anti-seizure medication, and IV anesthetic agent. Continuous EEG monitoring should be applied, and MRI evaluation should be done for a patient. If the patient had history of epilepsy and continue to have failure of medical therapy, then based on the MRI and the EEG, if there is abnormal and focal abnormalities in the brain imaging, then we have to consider echo-guided resective surgery or multiple subpial transection. If there is non-focal brain imaging and EEG, then we have to consider alternative therapies like ketogenic diet or electroconvulsive therapy, vagal nerve stimulation, and hypothermia. If you have a patient who, for the first time, presented with new onset refractory status epilepticus, we have to consider the autoimmune and paraneoplastic workup. If it is normal, then we go the same direction of patient who has epilepsy and presented with the status. If we identify autoimmune etiology, then we have to move with immune modulation therapy. If you fail the immune modulation therapy, then you go with the alternative therapy using a ketogenic diet or electroconvulsive therapy, vagal nerve stimulation, hypothermia. If you can identify the etiology that it is related to paraneoplastic, then you have to screen for the underlying tumor and treat according to this tumor. If you have a patient who had acute symptomatic etiology like infection or stroke, you have to treat with anti-seizure medication and treat underlying etiology. Very important message from this lecture that time is neuron, and we have to initiate the therapy early on. In patient who has epilepsy, we have to initiate and treat the parent how to initiate the therapy at home. A study showed that early intervention with benzodiazepine at home can lead to better control of the status early on using the diazepam or paclitaxel. So this is the message for all the neurologists to either in pediatric or adult to consider supplying the patient and the parent with the medication and teach them how to use it early on in the beginning of the status. This is a comparison between diazepam versus lorazepam. You can see here diazepam is highly effective in rapidly terminating the seizure, but the duration of action is shorter, and it's available in rectal gel, which is one of the advantages. Lorazepam equally or more effective than diazepam. Duration of action is longer, usually from 6 to 12 hours, less respiratory depression, and the disadvantage that there is no available rectal or buccal form. Second-line therapy is constitute of phenytoin. You can see clearly that phenytoin versus fosphenytoin. Unfortunately, phosphosphenytoin is not available in many centers. So although it is superior in the form of that rapidly can be infused more than the phenytoin, the risk of hypotension and arrhythmia is less with fosphenytoin as compared to phenytoin. Second-line therapy also include valproic acid, and the dose is ranging from 20 to 40 milligram per kg IV. Levetiracetam also commonly used, and it's available in IV form. Lacosamide is a promising medication, although the study still, we don't have a lot of studies supporting its use. However, in a review of 136 patients with refractory status treated with lacosamide, found that around 56% of cases respond and has a control for the refractory status epilepticus. Third-line therapy, phenobarbital, and if you consider it, you have to prepare yourself to intubate the child or the patient and shift to the ICU. This table summarizes all the options with the medication and the common side effect for the second line therapy and also the third line therapy, including the phenobarbital. Fourth line, which is used commonly in refractory and super refractory status epilepticus, we have many options, including midazolam, propofol, pentobarbital, thiopental, and ketamine. We'll go over it quickly. Midazolam is short half-life, can be given IV, continuous infusion. The dose from 0.1 to 0.3 milligram per kg, followed by 1 mic per kg per minute, maximum or 24 mic per kg per minute. Pentobarbital is short-acting, has been reported to be effective in around 74 to 100% in pediatric studies. The problem of pentobarbital is the side effect with significant respiratory depression, hypotension, myocardial depression, and pulmonary edema. Thiopental, used for refractory status, active metabolites which can accumulate, possibly a higher adverse reaction than pentobarbital. Propofol, IV anesthetic agent, small number of studies showed effectiveness. Risk of hypotension, apnea, bradycardia, as well as propofol infusion syndrome. It's contraindicated in patients with on ketogenic diets. So remember this information about propofol. Ketamine work on NMDA receptor blockage. It controls refractory status epilepticus in about 57% in a study which includes 110 adult patients. Side effect: hypertension, arrhythmia, anaphylaxis, pulmonary edema. Isoflurane is inhaled anesthetic agent. It has minimal reported organ toxicity because it is inhaled medication, rapidly can be titrated. It lowers the shivering threshold, works very well with hypothermia, and the evidence only limited to only some series and case report. This is again table summarize the IV infusions that used for refractory and super refractory status epilepticus. Other treatment options, we have surgical resection, repetitive transcranial magnetic stimulation, immunosuppression therapy using IVIG or steroid, immune modulation therapy with vagus nerve stimulation and deep brain stimulation, ketogenic diet, therapeutic hypothermia, magnesium sulfate, and virodoxin. Surgical therapy, in review of 23 patients, around 78.3% were seizure-free, and the type of surgery according to this study was involving either focal, lobar, or multilobar resection, corpus callosotomy, hysterectomy, or multiple subfield transection with or without focal resection. What about repetitive transcranial magnetic stimulation? Systematic review of 21 patients showed that seizure control or reduction occurred in around 71%. However, there is a problem with the relapse and recurrence and relapse, which is very high in such modality of treatment. And the study still is lacking the evidence and its use in general for refractory and super refractory status epilepticus. Electroconvulsive therapy. One systematic review found that in 19 patients underwent electroconvulsive therapy, 57.9 had seizure reduction or control. Immune modulation therapy, which include plasma exchange, IVIG, plus steroid or ACTH. Of course, if you are suspecting an underlying immunological process, that's the option, will be a good option for patients with suspected underlying immunological process. What about therapeutic hypothermia? Study showed in 270 patients with status epilepticus, when they compare standard of care and the standard of care plus hypothermia, and that study did not show better outcome in the patient treated with hypothermia. Ketogenic diet. Again, one study included 15 patients with refractory status epilepticus. They achieved ketosis after 2 days, and the resolution of superrefractory after 5 days reached 78.6%. The problem of ketogenic diet that the achievement of ketosis will take time, and you need a well-trained nurse and dietitian to monitor the patient closely. This is a diagram showing algorithm how to treat patient with refractory and super-refractory status epilepticus. You can see here that we start with mechanical EF ventilation, ICU admission, continuous EEG recording. Then we have to start the anti-seizure medication that the patient on, to start IV infusion using either midazolam or propofol, thiopental, pentobarbital, ketamine. In the super refractory, if there is no response to either of these medications, then we can move to the second, or the next line therapy, isoflurane. We can consider topiramate, magnesium sulfate, pyridoxine, and then immunomodulation therapy, which will come here. After that, if we fail, we can try ketogenic diet. Meanwhile, you assist the patient for neurosurgical resection or vagal nerve stimulation. This is another also algorithm which relatively simple as compared to the previous and more focused. So talking about using midazolam initially, then second line is ketamine, followed by pentobarbital, then other modalities of treatment, ketogenic diet, immunotherapy, pyridoxine, and epilepsy surgery. Ketamine also, in the clinical practice, we found that it has some effective and good outcome in some of the patients with super refractory status. So if we treat the patient and the patient stabilize, achieve the burst suppression pattern, how to wean off the infusion, this is depend on many factors. So if the duration of the anesthetic agent less than 48 hours, then the weaning can be over 6 to 12 hours, decrease rate by 15 to 30% every 2 hours. But if the duration is more than 48 hours, so we have to go slower and wean slowly, decrease the rate by 15 to 30% every 6 to 12 hours. At the same time, we have to consider adding benzodiazepine or barbiturate for during the withdrawal period of infusion, and that gives you buy time by introducing this modality of treatment during the weaning. So you will at least reduce the risk of recurrence of the status again. Very important message to add maintenance anti-seizure medication. And the anti-seizure medication, usually we start with higher dose rather than smaller dose at increase, because we are monitoring the patient in ICU. One important message to consider: combination of multiple anti-seizure medication with different mechanism. And this is, again, is very important to consider. Don't use all the anti-seizure medication that work on the same mechanism. Better to alternate and use more than mechanism of action. So by the end, the take-home message from this lecture, that status is common actually in children and adolescents. Early recognition and early therapeutic intervention is very crucial. Identifying the etiology will help in treatment options. Further studies are needed actually for management of refractory and super refractory status epilepticus, and it should be in a multi-center study rather than single center because of the rarity of the condition. With this, I conclude, and thank you all for your attention.